Hello, everyone. I'm Brian Bergstein, the Deputy Opinion Editor at the Boston Globe. And welcome to this Globe Op Talk on COVID-19 with Dr. Daniel Horne of Mass General Hospital. So Globe Op Talks is a new series of conversations that we've just launched in which members of the Boston Globe editorial board interview thinkers and other unique voices who contribute to the Globe's opinion and ideas pages. So today, let me get right into it because we have a lot to talk about and not a ton of time. Let me welcome Daniel Horne, who's a primary care doctor and director of population health in the Division of Internal Medicine at Mass General. So Daniel, thank you very much for being here.
Thanks for having me.
There's a lot of people here who are going to want to know basically what it is you do. Mass General is a huge institution. So why don't we start by, tell everybody what it is you do, both normally and all the hats you wear, and how that's changed in the last month or 6 weeks.
Sure. I, in what I call peacetime, I saw patients 3 days a week and taught the residents in their clinic sessions or sort of learning residents in internal medicine. And I ran all of our quality programs for primary care, a lot of sort of operations and innovation around care delivery for our primary care network, which is 21 practices across sort of eastern Massachusetts. And as the COVID crisis began, we were gathered together in our, what we call emergency command structure. And on the first day, we were told our job descriptions no longer applied and we were going to be deployed to do whatever we could do best. And so for the last 6 or so weeks, I've been leading our telemedicine implementation for our whole Department of Medicine, which is sort of all of our primary care doctors and our subspecialists, like our lung doctors and heart doctors and cancer doctors. And so that's been my biggest area of focus, along with thinking about how we can do proactive outreach to our frail elderly patients and kind of talk about how they're doing through this time when they're very socially isolated and vulnerable.
So there's a lot to get in there. I'll ask you some details about it. But, with all the attention on how the hospitals were preparing for this, I think the popular conception was we all thought about people who were going to the hospital. But for a huge institution like Mass General, the work that you do, it's probably, you're having to think about how to care for people, many more people outside than coming in. And is there any way to quantify that? Like how much telemedicine has ramped up, over the last few weeks?
Well, I mean, overall, the number of visits, what we're calling visits, has drastically dropped, but 80% of the care we're providing right now in clinic or in the non-hospital setting across our 250,000 primary care patients that we care for is through telemedicine. So it's a huge change. We're only seeing about 10 to 20% of our visits in the office. And those are people that really have kind of emergency or urgencies that, hopefully can avoid the emergency room that we can handle in the office, but all the rest of care is being delivered by telemedicine now.
All right, so we'll talk about that more in a little bit. Let's start with a high level view of what it's like inside MGH. So you led a lot of the preparations. You were part of the team that, were preparing for how you would deal with an influx of cases and, what's sort of a high level status update across the hospital and how have things played out compared to how you planned for it? How much has it met the expectations you had at the time?
Sure. I would just start by saying that's right. I'm certainly not the leader of the preparations. I'm a lucky member of the team and have been able to benefit from truly inspirational leadership here, which I hope the story of our leaders gets told one day because it really has been really an inspiration to watch. Where we are now at Mass General is that we are caring for 304 patients in the hospital with COVID-19. 135 of them are in the ICU, which is 3 to 4 times our usual ICU capacity at this point. We've been opening new dedicated coronavirus hospital floors for weeks and new ICUs, it seems, every day or two. It's, again, an inspiration to see. Everyone is doing their part. Morale is high. People feel supported. All hands are on deck. Staff have been redeployed from all areas of the hospital to do coronavirus care in a way that I could never have imagined possible. And we are seeing, we are clearly in the surge. We have sort of most of those patients in the ICU are on ventilators. the operating rooms are serving as ICUs. We have, prior sort of nurse anesthetists running the ventilators for ICU patients. I mean, it's just a sea change in care. And I think we're doing a marvelous job.
Are there enough ventilators?
We are able and open to care for any patient in need at this point, and we're really hopeful and optimistic that we'll be able to continue doing so.
So what, if anything, has been different from what you expected, say, a month out? You and I actually first spoke, I think it was March 15th, and you felt like at the time you wanted to get the word out to people. That was the weekend where social distancing was maybe not being taken as seriously as necessary. And we spoke that Sunday night, and you said, look, we feel like we're planning, to be on the front lines of a war, and you got to trust me that, we need all of you to do your part. It was completely understandable sentiment. I'm just curious how much, were you able to prepare for what ended up coming, and what surprises have arisen?
Sure. I mean, I think I would share two thoughts there. The first is that I am proud of the action Massachusetts has taken around social distancing, and the leadership we're seeing at the state and local level to continue emphasizing the importance of maintaining social distancing. It is our primary tool to keep people from getting sick, and our primary tool from keeping our hospitals compensated in Massachusetts and able to care for patients. And it needs to be maintained. We're in the peak right now, and I expect that the peak will continue to rise over the coming days, and then we'll have sort of a plateau for a while because patients are remaining on ventilators for 3 to 4 weeks at times who end up needing the ICU and needing a ventilator. And so we're still in this, and I would say the social distancing measures are crucial and they need to be maintained. For people who are going out, to wear a mask as the CDC has advised. I strongly recommend that. The other thing I will say about Massachusetts, and certainly about sort of MGH and other partner hospitals, but hopefully across Boston, is that we've seen really nice response around the PPE shortage, and I think we're lucky in Massachusetts to have visionary leadership there, thought leadership, and resources. I think both sort of luminary figures who stood up and said healthcare workers should wear a mask all day early on. I think that will save healthcare workers' lives and reduce transmission in healthcare substantially, and has become a national model where other health systems can, sort of have the supplies and have the masks to give their workers. We're seeing that happen, and that's a great thing. And then the sort of N95 masks and the surgical masks that have come through, through the Patriots plane and other, major efforts, again, in really important public-private partnerships. It's been a sigh of relief, certainly. Though the uncertainty we had to experience, being in the hospital without clarity on when that would come was difficult. But I think now we're on the other side of that, and that's a great thing.
Does the medical community, let me preface this by saying this is a question quite a few subscribers asked when they signed up for this and submitted questions. Does the medical community here still need, or does MGH still need donated masks, face shields? I mean, people want to know what tangible things they can do to help.
Yep. I mean, I think there are a number of things people can do. And some of this is for Mass General, and some of this should be for our community hospitals, for Boston Medical Center. I think people should think broadly about the medical community in Boston, which is so large and so important. For Mass General in particular, we have a website that, kind of addresses all means of possible donations, and we're really happy to have people support. It's massgeneral.org/news/coronavirus/how-you-can-help. You can find that if you just Google it as well. And that's a place where people can go to sort of share what support they could offer. And I would say, whatever ideas people have, we welcome them. We've seen things like coaching firms step up and offer, coaching for our physicians who have now been pulled into leadership roles on these new coronavirus floors. And I think that's going to be an amazing asset. The food donations are really helpful as long as they're coordinated. And so those are great things. I would also, again, look at other hospitals and their needs. I would say the other big way that people can save lives is by donating blood through this crisis. People are still bleeding, people still need platelets and other blood products. And the last I heard, the Mass General Blood Bank was doing okay, but we have a website where people can sign up for an appointment. The setup there is you have a fixed time, you come in, infection control is really careful, and it is a reason to leave your house and do something good for someone else. But again, I would look at other hospitals as well and their needs at their blood bank and make a donation if you can.
Is there a way to,
oh yeah, go ahead.
well, is there a way to combine blood donation with serological testing where people who donate will also find out if they have antibodies indicative of past exposure to COVID-19?
A number of our hospitals are doing trials. I'm not close to the trial efforts, but I think certainly as you look at the blood banks, it's a fair question to ask. And again, a number of these trials are publicly enrolling and people can find them on the internet. We need serologic testing. We don't have a definitive serologic test at this point, but I certainly hope it comes. I think it's important.
So we've talked in the past few days, you and I, not only about what's going on in the hospital, but what's happening out in the community where outbreaks are especially bad. And it's been troubling to see Chelsea, Massachusetts in particular, being a hot spot. And MGH has a large presence there. And so I was wondering if you could talk a little bit more about what's going on there and what could be done about it. And, you know, if you're comfortable saying, you know, should the state's relief efforts, you know, be prioritized to places like that? Is there a way that we can not just lament this fact, but spring into action in these community hotspots that are, you know, again, outside of the hospitals that have gotten so much justifiable attention?
Yeah, this is a really important issue, and I'll share some facts here, and then you know, my thoughts on solutions. You know, Chelsea has a case rate of 140 per 10,000 people. The next highest is Lawrence and then Brockton. And these communities are seeing case rates of coronavirus that are 3 to 4 times higher than the rest of Massachusetts. Coronavirus is quickly becoming a black and brown epidemic across the country. And I think the more concerning thing is we're seeing that 35 to 40% of our admitted patients in the hospital with coronavirus are Hispanic in Mass General. And that certainly far outpaces the demographics of Boston. It's a deeply concerning statistic. And we see similar phenomena in New York and Detroit. And the point here is that social distancing is a privilege. The ability to sort of isolate yourself from society and, you know, have space to do that safely is not something available to many people. Particularly, it's not available to many essential workers, the grocery store workers, the tea drivers and bus drivers, the hospital janitors who are helping maintain cleanliness in our hospitals who have to work. And at the same time, many of these people are living in homes that have that are crowded. And so they cannot quarantine if they get sick. And we know that a primary mode of transmission of coronavirus is in the home through family clusters. And so that is what we're seeing. And I agree that we need solutions. Partners and Mass General are committed to helping in Chelsea, and we have sort of 4 efforts underway as of this week. The first is that Chelsea will be a place where testing is dramatically expanded because the case rate is so high. We really feel we need to understand the epidemiology, the spread, the degree of coronavirus incidence in the community so that we can do sort of case finding and so that we can help with isolation of cases. We're going to do door-to-door distribution of what we're calling care kits. We're going to plan to give out 25,000 masks, coronavirus information, soap and cleaning solution for residents in Chelsea. We're going to help with isolation. This is a partnership across the hospitals, the community, and the state government. There's a Quality Inn that has been sort of hired out to become a hospital light for patients who can't be isolated in their home because their living environment is unstable or sort of unsafe due to presence of other family members. And then we're going to try to do as aggressive a communication and sort of surveillance and tracking campaign. We're going to deploy a large pool of nurse case managers to be calling patients diagnosed with coronavirus in these communities to do proactive sort of coaching of these patients and symptom checks with a lot of frequency and help talk them through this. Because again, the reason that we're seeing so many patients in the hospital is because they're presenting to care late and may not know to come in when they need to. And that's a concern for us.
Let me just stop you there. So again, for the people watching, you're a primary care doctor, but this is, general advice, not, specific to anyone's case. That should be one caveat. It's also April 14th, and the data and what we know around this disease changes fast. But that said, what you just said, people are presenting to care late. At the same time, you also don't want people rushing to the hospital if they have just a sore throat. So what should people do? I think this is a tricky thing for a lot of people. They want to know if they think they might have it, or they fear that they're likely to get it. What's your best advice at that kind of high level?
Yeah, it's an important question. Certainly, again, I'm not giving anyone specific medical advice here, but I think the high points and what we know today is, if you have a flu-like illness, which is cough, runny nose, the loss of taste is a prominent symptom, some diarrhea, body aches, fever. We do still want you to stay at home. We do want you to reach out to your doctor by phone and have someone walk through symptoms with you and give you advice. However, if you are developing shortness of breath or dizziness, mild shortness of breath, mild dizziness, we want you to be seen. We at Mass General, if you're a patient at Mass General, you have access to something we call a dedicated respiratory illness clinic where we can manage you and provide guidance and do a proper evaluation and workup. I will say though, if you're having any progressive difficulty breathing, worsening dizziness, trouble keeping food or water down, that's a time to come to the ER, because we are seeing that coronavirus patients are crashing quickly. The other thing to say is that some of the timelines around coronavirus are very different than other illnesses, where patients are sort of developing this sort of trouble breathing, the lungs filling up with fluid at days 6 through 10 after onset of symptoms. And that's really unlike other things. And so that's a time to really be very self-aware around what's going on with you if you're sick. And again, to present to care so that we can care for you in the hospital. And we're ready to do that. I think those are the key lessons that we know so far. And
as far as stocking up on any over-the-counter medicines or anything like that?
Yeah, we're doing a lot of clinical trials in the hospital with a rapidity that I've never seen in healthcare. And I think we're going to learn quickly. I think for people at home, the hoarding of medicines, particularly the medicines that are continuously referred to in the White House briefings, is causing a lot of problems. The problems it's causing are for patients who are in the hospital that we may want to use some of these on as part of the trials. We don't have supply. For patients with other medical conditions who need hydroxychloroquine, which is a common drug used in what we call rheumatologic or immune conditions, they're not able to get their medicine. And so don't hoard these medicines at home. There's no evidence they help, and they're needed elsewhere.
Got it. So let's go back to the situation that you described in Chelsea, where there's this surge, for lack of a better word, of getting people more likely, in position to be isolated if that's what they need. These 25,000 masks. Who's funding this, and how long can it last? An effort like this.
The funding questions are tricky. We're doing what we need to do in healthcare right now, and I would just say any question about funding gets me nervous because, I'm fortunate not to be thinking about it, but there's a moment coming in healthcare where we're going to realize that people who are out there fighting really hard for our communities, for our patients, these amazing people, are going to have to shut down their businesses or face salary cuts or furloughs. And it's just whenever I think about that, I just get really upset because the business of medicine is a business that's run on visits. We get paid in medicine when we see patients in the office, and suddenly 6 weeks ago, the right thing to do for people was to stop seeing patients in the office. And yes, it's true that the Center for Medicare Services and our big payers in Massachusetts are all paying for telemedicine. But interestingly, Medicare in particular for phone calls, right, which most of our doctors are finding to be incredibly meaningful and important ways to care for our patients today. Just a good old phone call, right? Not forcing an 88-year-old to struggle with video technology, or someone who doesn't have a computer to struggle with video technology. Just getting on the phone has proven to be an incredibly meaningful thing. And Medicare is paying out about half the rate for phone calls as they are for visits, for video visits or in-person visits. And yet it's most of what we're doing, frankly. And so there's a problem there. And places like ours can stomach this, we hope. And our leadership has been incredible in providing reassurance. But we're already seeing community hospitals, we're seeing community practices really struggle financially, laying off large portions of their administrative staff. And there are some projections that say that 60,000 small to medium primary care practices will disappear from this country over the next 3 months. And when this is over, you're going to need primary care. The country's going to need primary care. And it's a deeply concerning projection to me.
This feels like an unspoken or underappreciated aspect of what we're going through right now. I mean, first of all, the business of healthcare is hard to understand, even, for most of us, even under the best circumstances. But I think this is just an underappreciated. I've talked to people at big hospitals too, who say they're running out of cash. I mean, elective procedures aren't happening. And so certainly the need sounds acute in primary care, small clinics that, probably treat the vast majority of Americans. I mean, this is something, it sounds like something that needs to be elevated as an idea, as another part of.
I would agree. And the truth is, there's a solution that is fairly straightforward, which is something called a global budget, which is something that we've wanted in primary care for a long time. We have felt for a long time that the best way to care for patients, for a population of patients over time, to care for you over time, is that if you're my patient, we get paid a fixed amount every month to care for you in whatever way is necessary, rather than dragging you into the office, potentially unnecessarily for care, right? And so particularly in this emergency, when bringing people into the office is a terrible idea for routine care, right? An emergency global budget, something on the order of $75 to $100 per patient per month from Medicare or from our commercial payers into primary care will save primary care through this crisis. And it's a really important idea for us to consider.
This may be further than you want to go, but a lot of listeners will be hearing us talk about this and say, this sounds like the greatest argument ever for universal health care.
I think it's going to be the most important conversation we will have coming out of this. I agree.
So let's talk a little bit more about telemedicine, which is actually not a new technology or not a new idea. I just actually learned today that it was a physician at Mass General in the 60s who coined the term. It's something that is suboptimal, right, for a lot of situations, but optimal for a lot of, a lot of things that will save people the time from having to come in. Obviously, there's issues around the equitability of the access, who has the broadband for a video call and so on. But talk a little bit about how the use of telemedicine that you and your colleagues have been, the telemedicine that you've been using this last month or so, what is that telling you about what's going to happen over the long term? Are we all now, is this going to stick? Are we all going to be, Zooming with our doctors far more? And, what would be as you see it as a primary care doc, the pluses and minuses of that?
Sure. I mean, I do think it will be here to stay. I can't imagine going back. I will say that it's not a panacea. I think that, as I talked to a lot of my colleagues and my own experience, like it is great for mental health care. It is great for family meetings. It is great for a lot of chronic disease check-ins, particularly if you can do things like check your own blood pressure or your own sugar levels at home. It is great for that. I don't think it's great for complex diagnostic workup. There's a lot about being together in an office with someone else and having a human connection that makes a difference. I would also say that, telemedicine is not just about, a video call like we're having here. It's about, questionnaires and surveys and text messaging with healthcare. There's a lot to do, and there's a lot of capacity to do it. It's about, remote monitoring and, things like, having devices in people's homes that we can build out over time that tell us a lot more through a video call than we can do today. So I think this is a sea change that will stick.
We talk about devices that would be monitoring vital signs, for example.
Monitoring vital signs. You could envision that this becomes a thing. Like people would have stethoscopes at home to put on their own hearts so that we could hear it through the video. These don't exist today, but they should and they can. I think that, the one concern I would raise is that it mimics lots of other things, which is a lot of the video technology used in healthcare has not been built for equitable access, where it's just not as easy to do a video through your phone as it is on a tablet or a computer for whatever reason. The privacy and compliance concerns that dominate routine healthcare, right? Sort of make it so that patients that have poor language proficiency or, again, poor technology access have a much harder time getting onto our portals and things like that. And I think, when this was like a 1% to 2% of care is done this way, that was all kind of okay. When it's 80%, it's absolutely not okay. And I think we really all need to be paying attention to that.
A reader or a subscriber, a viewer who RSVP'd for this beforehand asked or wanted us to discuss whether there's a need for a national telemedicine platform, or whether it's going to be best left to individual providers to figure it out, let a thousand flowers bloom kind of thing.
I think we should have some standards, but I think we should let a thousand flowers bloom. In particular, I would say that this is an industry that was disrupted overnight. I'm using a platform that is free for basic functionality for any doctor across the country, and so many others are too. While our organization tries to build in, an institutional software, that meets all of the compliance and regulatory requirements. And that's important, but it's taking a while and we needed an alternative. And so we found one that was just sort of available on the internet. And that's what I'm using because I need to take care of my patients today. And so this industry has been disrupted. I think we should continue allowing innovation to happen. And I think we'll see a lot of growth in this space over time.
So all of us, probably the one universal about me, you, and everyone on this call, we all want to know when we can perhaps start to relax the current situation we're in. And Globe readers who saw the page one story on Sunday from my counterparts on the news side, David Abel and Naomi Martin, had this story that really effectively, I think, laid out, what, at least in Massachusetts, is going to take for the governor to say, okay, look, we can start to relax, let up a little bit. And those three criteria, at least as now, are 14 straight days of a declining caseload, and which is a easily quantifiable figure. Amount of tests available that basically anyone with symptoms can be tested. Also something that we, should be able to count and quantify. But there's a third factor that's going into this consideration as well, and that is whether the healthcare system really is able to treat everybody who could possibly come in, given what we could project. Anyway, that last bit is a little bit trickier. That's a little bit more qualitative than quantitative. You know, whether hospitals can safely treat all the COVID-19 patients. How would we know whether that criterion has been achieved? I mean, if it's is requiring not only the hospitals to have a certain number of ventilators and a certain number of ICU space, but also these out in the community center interventions like hotels being converted to isolation. I mean, that it feels like we might be further away on that count than the others. And I'm just sort of curious, how will we know when we've reached that safe criterion?
Yeah, I agree. I think the case count is the case count, and hospital capacity is something that is being reported, certainly, internally to the governor, and fairly transparently as well. So those two things are known, and I would say we know we're in the surge now, and we do expect again the plateau, and then a declining case count. I would say nationally, the travesty here is the lack of rapid testing. There is no plan, as I see it, for this country. And I agree, it is a crucial step. We need rapid testing and what's called contact tracing, which is the ability to find, in the case of a positive coronavirus, a patient who has coronavirus, newly diagnosed, we need to quickly find the people that they have interacted with over the last, 7 to 14 days and isolate them. And that's how we reopen the country. The upside that I see is that it does seem like Massachusetts is going to lead in this space. Governor Baker has launched some really promising partnerships with a number of organizations. One of them notable to me is Partners in Health, founded by Paul Farmer, that has cut their teeth battling epidemics across the world. And they're going to be working in Boston here, along with many others. The one piece that I want to start talking openly about that is difficult to talk about is what we think we know about coronavirus is that the spread is so fast and the number of asymptomatic spreaders is so high that, like any manual process of sort of talking to you and getting the list of people you think you've interacted with is not going to work. We are going to need an electronic methodology using things like cell phone tracking data to do this. And, that is going to be a hard thing to talk about and explain to people, but all the science that I see supports that is what is going to be necessary to do rapid testing and contact tracing. Those are two different things. We don't have rapid testing. So again, I know that the state is pushing to get there, but we just don't have it now. And the country certainly doesn't have it. I mean, the stories of people waiting all night in New Jersey, shaking with the flu are tragic to me. And then the second one is we don't have a public health infrastructure here in Massachusetts at this point, and certainly nowhere else in the country, that involves the people that we will need to do all this contact tracing and the technology that we will need. And that's where we've got to get. And
yeah,
it's a huge.
That's why I was asking how we could know what is the point at which the hospitals could safely treat all the COVID-19 patients, because we still don't know that question of how fast it's spreading once we're all kind of, not social distancing as much. We don't know how many people already have had it. We don't know the extent to which they're immune and so on. So I think this is why it's hard to imagine even those other two numbers could be where we want them, but until we have the testing, we don't know. That sort of sounds why testing is really the key linchpin there.
Yeah.
So you wrote a piece in the Globe with your colleague Juliet Jacobson a couple weeks ago, talking about how people need to be prepared to have what you called a serious illness conversation. And it was very striking, very memorable. I was wondering if you would share your thoughts on that. What does that mean to have such a conversation with your doctor or with your family?
So, what we know is that, if you're above 80 and you get coronavirus, the sort of rate of serious illness is very high. And above 70, particularly with other chronic conditions, again, the rate of serious illness is very high. And so I think there's a bunch of issues here that are important. One is that we know a lot of people above 70 and above 80 are living alone through this, or with caregivers that are healthcare workers and may or may not be able to sustain their commitment as they travel across the city and sort of take care of multiple patients. They may not be able to kind of stay connected to patients appropriately. And so what we've committed to for our patients is to reach out to around 20,000 patients over the next few weeks to really ask them how they're doing on food security, loneliness, do they have caregivers available to them, and also to talk to them about whether they've thought about what they would want if they got seriously sick. Because people are crashing so fast, late in the disease as they come into the hospital, that they don't have time to tell us what they want or what they would have wanted. And so we're trying to help reach out to our patients to have that conversation. And I would also urge viewers to look at websites like prepareforyourcare.org to think about what they would want, particularly if they are vulnerable, sort of older patients or have other medical conditions, and think about what they would want if the worst were to happen, and to also make sure that they know who their decision maker might be if they're unable to make decisions for themselves, and have had that conversation with that person about how that person might represent them in that moment. And that's a hard thing to talk about. It's a sad thing to talk about. But I do think that, my belief is that by giving people agency, we are empowering them to have happen what they would want to happen. And generally, these conversations don't have conclusions. They're not about a decision. They're about a thought process. They're about understanding the issues, understanding some of the clinical guidance I talked about, making sure people are doing okay, making sure they know when and how to ask for help, but also that they're starting to have this kind of conversation about what would happen in serious illness. And it's been a very meaningful undertaking for us, and I think for our patients as well.
All right, so at this point, I want to bring in Chris Avello. He's the Director of Subscriber Experience at the Globe, and he's going to share some of the questions that viewers have been submitting during this chat. And so he's going to join us to share some of the questions he has selected. So Chris, welcome.
Thank you, Brian. And I just want to quickly say thank you to all the Globe subscribers and readers who submitted questions. We're actually overwhelmed at the moment with the number of questions coming in. So sorting through them has been a challenge, but a fun one. So thank you guys so much for being so engaged. And for you, Doctor, so many people just use the opportunity, instead of asking questions, to just say thank you to you for what you're doing in general and today with your time. So thank you.
Yeah, I mean, the thanks needs to go to everyone else, honestly, in our hospitals. These are not just great healthcare workers, they're great people. And, it's just such an honor to know all of them.
That's great. So one thing that people were interested in, and this particular question comes from Abigail D. She said, can you speak to the topic of mental health for those who are currently on the front lines caring for patients, both right now, but also over the long term?
Yeah, I mean, I think it's an issue. I had a lovely therapist I used to talk to once a month that I talk to twice a week now on video, and it just helped me get through things. I would say some of the things I'm thinking about, I am just sharing thoughts without solutions. Our residents, and our fellows are being deployed to run these ICUs in large part, and they're going to see a lot of what's about to happen, and they're going to need to process. Again, some of the anxiety around the personal protective equipment and all the uncertainty there, I just think, it's just again, an unnecessary added anxiety for all of us here stepping up. And I think people are going to simultaneously deal with loss of patients, which is extremely hard. And I think many of us all know family, friends, and loved ones who are dying at the same time. And I think that sort of schism that a multitude of events is going to be very hard. And then the fact that many of us are, have families and have partners who, are struggling to work while homeschooling children. And I would say another thing that people can do is to just reach out to partners of healthcare workers to check in, because, a lot of people, it's good to have two parents at home. And I think if you're a healthcare worker, in a 2-parent family, you have 1 parent at home right now. And I think that that's hard. I don't know, range of thoughts. I think every hospital needs solutions and needs a plan. We have a number of things going on which are positive, but it's an important thing. Mental health across the country is going to be a really important thing when this is over as well, as people have lost jobs, facing uncertainty in their homes. We know that the rate of domestic violence, child abuse, depression, substance misuse is going to go up very substantially. And so we will need a national mental health plan. Like, this is stuff we're terrible at in this country that needs to be addressed coming out of this. And we all hope that it will happen. Seems like really kind of state by state leadership is going to be key for us, unfortunately.
Got it. Thank you. So this one is from Elaine A. She said, upon hopeful and potential availability of a vaccine, do you have a sense of how it might be distributed and how a hospital like MGH would play a part in that kind of supply chain and distribution?
Yeah, it's a really important question. I have no expertise in the space, but I agree it's a crucial question. And I'm hoping we're going to see a lot more coming. There's a good article about sort of coronavirus immunity in the New York Times yesterday, I believe it was, that I think is a must read for everyone. Because there's questions about whether immunity will be sustained for more than a year or two. So again, this is a moment of profound uncertainty.
Cool. And I'll ask one more from our viewers, and this one was from Ninad K. What are the biggest lessons learned so far in terms of preparation? And are you confident that we can be better prepared as a nation next time for something like this?
I think we're all hopeful for profound change. I think that the preparedness, so the preparedness that I see at Mass General is truly mind-blowing and inspirational. Again, like, we built buildings years ago with the notion that one day entire floors of those buildings would need to be converted to ICUs. That's incredible. The command and control mentality where our leaders, our what we call our incident commander, our physician in chief, gathered teams together and told them with visionary clarity what needed to happen and by when, was incredible. And then we delivered. We haven't seen that on a national level. And again, that's a travesty. And I certainly hope that we will learn from this as a nation and never allow this to happen again.
Great. Well, thank you for those. And thank you again to everybody who submitted questions. Sorry we couldn't get to all of them. There were so many. Yeah.
And Dr. Horne, thank you again for joining. And, I really, really appreciate it. I urge everybody out there who hasn't yet to go to Globe Opinion and read the piece that Dr. Horne and Dr. Jacobson wrote earlier in April about the serious illness conversation. And in general, Globe Op Talks is an experiment, so we'd love your feedback on that. And we welcome you to join us for future Op Talks. You can look for one next Monday, led by my colleague, Renee Graham. So until then, thank you for joining us. And Dr. Horne, good luck. Thank you.
Thank you. Stay healthy, everybody.